Hey radiotherapy students, in this video we're going to talk through pelvis pre-treatment localization in radiotherapy. Now CT localization can sometimes look like a simple scan appointment, but it is actually one of the most important parts of the whole radiotherapy pathway. This is the point where we position the patient, immobilize them, scan them, mark them, and document exactly how they need to be set up for treatment. We are essentially creating the reference position that the planning team, the treatment team, and the image guidance process will all rely on. If the localization is accurate, it gives the patient a strong foundation for safe and reproducible treatment. But if the CT localization is poor, that problem can follow the patient through contouring, planning, image matching, and treatment delivery. So, why does CT localization matter? The main reason is that it connects the patient's real anatomy to the treatment plan. During localization, we are trying to reproduce the position the patient will be treated in, create an accurate planning data set, support target and organ at risk contouring, support dose calculation, and provide a reference image for daily image guidance. This is especially important in the pelvis because pelvic anatomy is not fixed. The bladder can be fuller or emptier. The rectum may contain gas or feces. The prostate, seminal vesicles, uterus, cervix, vaginal vault, and pelvic lymph nodes can all be affected by internal organ motion and patient preparation. Before the patient is scanned, the first step is confirmation. This is where we check that we have the correct patient, the correct diagnosis, the correct treatment site, the correct treatment intent, the correct dose and fractionation, and the correct scan extent. And this is really important because not every pelvic patient needs the same scan range. For example, a prostate-only patient may not need the same superior scan extent as a patient having prostate and pelvic nodal radiotherapy. A rectal cancer patient may need the scan to extend down below the perineum. A gynecological patient may need a scan range that captures the uterus, cervix, vaginal vault, pelvic nodes, and organs at risk. So before the patient even goes into the scanner, the radiotherapy team needs to understand exactly what is being treated and why. This helps prevent avoidable errors, such as scanning too short, missing nodal regions, missing target volumes, or not including the anatomy needed for accurate image matching. The next part is consent and safety screening. The patient needs to understand what CT simulation is, what will happen during the appointment, and why the scan is needed for radiotherapy planning. This is also where we explain things like bladder preparation, bowel preparation, skin marks, tattoos, and any contrast that may be required. At the same time, the team must complete the relevant safety checks. Pregnancy status should be checked where appropriate. Fertility concerns should be discussed when relevant. We also need to ask about implants, pacemakers, ICDs, hip replacements, metalwork, or any other device that may affect scanning, imaging, or treatment planning. And if contrast is being considered, the patient must be screened properly. That includes renal function, allergy history, previous contrast reactions, medication considerations, and local departmental contraindications. The next step is preparing the anatomy. For pelvic patients, bladder and bowel preparation can make a big difference to localization quality. Depending on the treatment site and local protocol, the patient may be asked to drink a specific amount of water before the scan or attend with a comfortably full bladder. They may also be given bowel preparation advice. This could include using a microenema, taking laxatives, or following specific instructions to help empty the rectum before scanning. The reason we do this is reproducibility. A rectum full of gas or feces can push the prostate, seminal vesicles, cervix, uterus, or vaginal vault away from the planned position. A very empty bladder can allow more small bowel to fall into the pelvis, which may increase bowel dose. But a very full bladder can be uncomfortable and difficult for the patient to reproduce every day. Most pelvic patients are positioned supine for CT localization. Supine simply means the patient is lying on their back. Common pelvic immobilization may include a knee rest, ankle stocks or foot stocks, a head support, arms placed on the chest, and an index set up so the position can be reproduced accurately. The purpose of immobilization is to reduce variation. We want to reduce changes in pelvic tilt, hip rotation, leg position, and body rotation. This becomes even more important when the treatment volume is long. For example, if pelvic nodes or para-aortic nodes are included, even a small rotation at the pelvis can create a much bigger displacement at the superior or inferior end of the treatment field. Once the patient is immobilized, the next step is alignment. The radiographers use the room lasers to align the patient and check that the pelvis and torso are straight. They will also record the couch position, immobilization devices, indexing positions, and any setup details that the treatment team will need later. In some departments, setup photographs may also be taken to help reproduce the position on the treatment unit. This is a critical stage because the position used at CT becomes the planned reference setup. Before scanning, we also need to think about artifacts and patient dignity. Anything removable that could create artifacts should be considered. This may include metal objects, jewelry, body piercings, clothing fastenings, or unnecessary external objects. Artifacts can obscure anatomy, make contouring more difficult, and affect the accuracy of dose calculation. But at the same time, pelvic localization can feel very vulnerable for patients. They may need to expose the marking area, but only the necessary area should be exposed. Clear communication, appropriate draping, and reassurance are essential. And this is not just about being kind, although that is obviously important. It also affects the quality of the scan. If a patient feels embarrassed, tense, cold, or uncomfortable, they may move, rotate, or struggle to maintain the position. Contrast use depends on the treatment site, local protocol, and the patient's safety screening. IV contrast may be used to improve visualization of pelvic vessels and lymph nodes. This can be useful because pelvic lymph node regions are often contoured around the pelvic vessels. Oral contrast may also be used in selected cases to help identify small bowel, particularly in some rectal, anal, or pelvic nodal treatments. But contrast should never be used casually. Before giving contrast, the team must check renal function, allergy history, previous contrast reactions, medication risks, and departmental guidance. Once the patient is positioned, prepared, aligned, and checked, the planning CT scan is acquired. This scan gives us the patient's external body contour, internal anatomy, and Hounsfield unit information. Hounsfield units, or HU, are important because they allow the treatment planning system to estimate tissue density and calculate dose distribution. The CT dataset is also used for target contouring and organ at risk contouring, and later on it becomes the reference image for treatment verification, such as CB-CT image matching. This is why a radiotherapy planning CT is different from a diagnostic CT. A diagnostic CT is mainly used to identify, stage, or assess disease. A radiotherapy planning CT is used to plan and deliver treatment accurately. Now let's talk about scan range, starting with prostate and bladder patients. For prostate patients with or without pelvic nodes, the planning CT is usually acquired using thin slices, often around 3 millimeters or less, depending on local protocol. For prostate and seminal vesicle treatments, the scan may extend from around the top of L4 or the top of the sacroiliac joints down to approximately 1.5 centimeters below the ischial tuberosities. If pelvic nodes are being treated, the scan extent usually needs to be higher, often towards L3 or L4, again depending on departmental protocol. The scan needs to include the prostate, seminal vesicles, pelvic nodes if treated, bladder, rectum, femoral heads, and enough bony anatomy for accurate matching. For bladder patients, the scan needs to cover the whole bladder and the surrounding relevant anatomy. Bladder size and shape can change a lot from day to day. That is why some bladder pathways use an empty bladder approach and some departments use plan-of-the-day adaptive radiotherapy. For rectal cancer, CT slice thickness is also commonly around 3 millimeters or less. The scan may extend from the top of the iliac crests down to below the perineum. This helps ensure that the scan includes the tumor, mesorectum, pelvic nodes, anal verge or perineum if relevant, bowel and the organs at risk. For anal cancer, the scan range is also commonly from the top of the iliac crests to below the perineum. But if involved nodes or high pelvic nodes are present, the superior extent may need to be extended. This matters because anal cancer treatment may include the anal canal, perianal region, inguinal nodes, pelvic nodes, and skin extent. If the scan is too short, you may miss target anatomy, nodal regions, bolus regions, or useful anatomy for image matching. And if important anatomy is missed at CT, the patient may need to be rescanned before treatment can be planned safely. For cervix or endometrial patients, a 3D CT with thin slices is commonly used. Depending on the protocol, full and empty bladder scans may be considered for ITV delineation. ITV stands for internal target volume. We use an ITV when the target can move internally, for example, because of bladder filling, rectal filling, or other internal organ motion. In gynecological radiotherapy, the uterus, cervix, or vaginal vault can move depending on the bladder and rectum. After the planning CT is acquired, the team needs to decide whether the scan is acceptable or whether it should be repeated. This is a really important quality check. The team should confirm the correct patient, correct site, and correct scan extent. They should assess whether the bladder and rectum are within protocol, whether there is significant artifact, whether the markers are visible, and whether there is any major patient rotation. They should also consider whether the patient moved during the scan, whether any relevant anatomy is missing, and whether the immobilisation and setup have been documented properly. So if the bladder is too empty, the rectum is too full, the patient is rotated, the scan range is too short, or the markers are missing, the planning process may be compromised. Repeating a scan at this stage can feel inconvenient, especially in a busy department, but it is much safer to correct the problem at localization than to discover it later during planning or, even worse, during treatment. Once the scan is accepted, the patient may receive tattoos or surface marks. These marks help align the patient with the room lasers during daily treatment setup, but it is important to remember that tattoos are not the treatment target. They are external setup references that help link the patient's surface position to the internal CT reference geometry. Some departments now use tattoo-free workflows with surface-guided radiotherapy, but tattoos are still common in many centres. After marking, the setup must be recorded clearly. This includes the patient position, arm position, headrest, knee rest, ankle support, indexing positions, bladder and bowel instructions, contrast details, scan range, tattoo or marker positions, and any difficulties or deviations during the appointment. This documentation is essential because the treatment radiographers need to reproduce the CT setup every day. Once that is complete, the CT dataset and setup information are transferred to the treatment planning system, where contouring, planning, and dose calculation can begin. After localization, contouring is performed. The clinician defines the relevant target volumes and organs at risk. GTV stands for gross tumor volume. This is the visible or known tumor. CTV stands for clinical target volume. This includes the GTV and areas at risk of microscopic disease. ITV stands for internal target volume. This accounts for internal motion where needed. PTV stands for planning target volume. This includes margins for setup uncertainty and internal variation. Common pelvic organs at risk include the the bladder, rectum, small bowel, sigmoid colon, femoral heads, and pelvic bone marrow. Depending on the treatment site and field extent, other organs may also be relevant. The planning CT allows the team to model the patient's anatomy in 3D, shape the dose around the target, and reduce dose to surrounding healthy tissues where possible. But the key point is this: the quality of the contouring and the treatment plan depends heavily on the quality of the localization scan. Now let's go through some common localization errors. The first one is the bladder not being at the correct protocol volume. If the bladder is not prepared correctly, it can change the position of the target and organs at risk. It may also increase the amount of small bowel sitting in the pelvis, which can increase bowel dose. The second error is a rectum full of gas or feces. This can shift the prostate, seminal vesicles, cervix, uterus, or vaginal vault. In prostate patients, for example, a full rectum can push the prostate anteriorly. In gynecological patients, rectal and bladder filling can significantly affect the internal target position. The third error is patient rotation or pelvic tilt. This is especially important for long pelvic fields. A small rotation at the pelvis can produce a much larger displacement at the top or bottom of the treatment volume. The fourth error is inadequate scan length. If the scan does not include the full target, nodal region, bolus region, or matching anatomy, the plan may be compromised and the patient may need a repeat CT. A few other localization errors are also worth mentioning. One is contrast not being given when it is required. If contrast is clinically needed but not used, pelvic vessels, lymph nodes, and soft tissue targets may be harder to identify and contour accurately. Another error is poor immobilization, especially unsupported legs. If the legs are not supported properly, hip rotation and pelvic pitch may vary between CT and daily treatment. This can change the relationship between the pelvis, target volume, organs at risk, and treatment beams. Poor documentation is another major issue. If the setup is not recorded clearly, the treatment team may not be able to reproduce the CT position accurately. This includes missing information about the knee rest position, ankle stocks, arm position, bladder preparation, bowel protocol, contrast use, or any patient-specific setup difficulties. Thanks for watching. Please like and comment, because it tells us that you want to see more radiotherapy teaching like this. And if you want to practice radiotherapy image matching and understand the clinical reasoning behind treatment decisions, make sure to check out radbud.com.